The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by independent educational grants from Lantheus Medical Imaging and Novartis Pharmaceuticals Corporation.
Good afternoon. My name is Jay Rahman, and I am professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this specific episode being one in a series that we've titled Discussions in Prostate Cancer. And in this particular episode, we're really going to dive deep into castrate-resistant prostate cancer and talk about sequencing of therapies and agents, as well as other assorted imaging findings. It's really my pleasure to introduce my guest, Dr. Alicia Morgans. Dr. Morgans has done a lot of programming with the AUA, and we shamelessly tap into her expertise because she's so good at what she does. So no good deed goes unpunished is the way I think about it. She's a GU medical oncologist, an associate professor of medicine at the Harvard Medical School, and she's the medical director of the survivorship program at the Dana-Farber Cancer Institute. Alicia, as always, you're a gem. Thank you so much always for being so kind to join us on our programs, and really our pleasure to host you.
Well, thank you so much for the invitation, and certainly my pleasure to be here.
So maybe just before we start diving into sort of, CRPC, let's just talk, maybe give us a 20,000 foot view, maybe give our listeners a little bit of a sense of what we are going to be covering, maybe over the next 30 minutes or so, and then we'll kind of dive into some of the details.
That sounds great. So we will do a bit of a review of mCRPC as a state and really consider the heterogeneous disease and recognize that there are many treatment options available. And then we'll walk through some of those options, because when we think about sequencing, of course, we have to recognize what our options are and then consider each of those in light of the disease state, the prior exposures to therapies, and different things. So we'll talk about PARPs, we'll talk about combinations with PARPs, we'll talk about radiopharmaceuticals, certainly an area that is changing pretty dramatically. We'll go into chemotherapy, which remains an option. And then we'll think about some of the lesser considered approaches, things like immunotherapy, which can still be a nice option, specifically for certain patients when we can consider pembrolizumab, as well as clinical trials, which are always really a critical part of our care in mCRPC.
So that's a great summary and a great, I think, overview of what we're going to touch on. So let's start with the first of those, and you sort of alluded to it, but I'm going to sort of, give you the broad framework of maybe walk our listeners through a little bit. We're talking about mCRPC, metastatic castrate-resistant prostate cancer, just even as a very basic point. What does that mean? How do we define that state? And then maybe talk to us a little bit more about then, some of the nuances with regards to mCRPC.
Sure. So castration-resistant prostate cancer is really a state defined by having a castrate level of testosterone less than 50, where we have a rising PSA despite that castrate level of testosterone. And typically guidelines recommend that we repeat the PSA to confirm that it's actually increasing and make sure that what we think we're seeing is what's actually happening. Metastatic is actually in this setting defined by conventional imaging. So the traditional mCRPC, or metastatic castration-resistant prostate cancer, would be defined by lesions that are identified on a bone scan or measurable on a CT scan, usually with IV contrast. That's chest, abdomen, and pelvis CT, and maybe an MRI could be used as well. If we think about PSMA PET, which is increasingly used in our prostate cancer population, this is not traditionally used to diagnose or document metastatic disease, although we absolutely use it in mCRPC when we're trying to use it to identify biomarkers for use of things like PSMA targeted radiopharmaceutical therapies. So that classic definition is going to adhere to conventional imaging demonstrating metastatic disease.
And I think that and you can correct me if I'm wrong, but we do sort of broadly group a large cohort of people into this term CRPC, but I'm sure you're going to explain to us that it's really more of a heterogeneous cohort of persons that and disease states that kind of fall into this. Can talk to us a little bit about how CRPC or MCRPC is not necessarily one uniform entity with one prototypical type patient.
It absolutely is not. It certainly can have certain diseases that are relatively slower growing. So not usually slowly growing, but relatively slower than others. And there are some whose cancer really just explodes despite maximal treatments with everything that we have available. So when we think about trying to classify in terms of this heterogeneous disease, I think the first place to start is the metastatic location, understanding whether patients have visceral involvement, particularly liver involvement or perhaps brain involvement, suggesting a particularly poor prognosis, but other visceral involvement also being important to recognize, things like lung involvement or soft tissue involvement like lymph node disease. If patients have bone-only involvement, they may be eligible for certain therapies, particularly things like radium-223, whereas if they have visceral disease, they may be more likely to have rapid progression or have more symptomatic or more aggressive disease. We also think about whether patients are symptomatic or not. That can dictate whether or not we would use certain therapies. One example might be not using Sipuleucel LT in patients who are symptomatic, as just one example, or potentially considering radium-223 in patients who have symptoms of bone pain as something that could both prolong life and address bone issues. The other reason to think about symptomatic disease is because we often use complementary therapies like palliative radiation to areas of bone that are causing pain. And treating MCRPC involves using both therapies that we know will be important in terms of disease control and prolonging life and having that disease-directed efficacy. But it's also important that we think about all of the supportive care that can be important for patients with MCRPC, including palliative radiation and certainly bone health support. I think the prior treatment exposure is something that also makes this a very heterogeneous disease state, with a group of patients who may have been exposed to things like AR pathway inhibitors and docetaxel chemotherapy, and others perhaps only receiving androgen deprivation therapy as prior treatments. And so these two populations or multiple populations are going to have very different, potentially mutations that are driving the cancer, certainly different resistance patterns that have developed based on those prior exposures. And finally, I think it's really critical that we remember for all patients with advanced prostate cancer that we should be thinking about germline and somatic genetic testing, because these can help us understand whether this might be a heritable cancer syndrome that's caused this cancer that might put it at risk for a poor prognosis overall, something like a BRCA2 mutation driving this cancer that's both related to a poor prognosis, but also identified as something that we can target with a PARP inhibitor. Our somatic testing and our germline testing might also be important in identifying other targets. Somatic testing, particularly in identifying things like P53, RB mutations, P10 mutations, where we might think about more androgen indifferent type phenotypes that might be more sensitive to things like adding carboplatin to our chemotherapies. And that's sort of a next level of chemotherapy manipulation. But all of this is really important as we understand and increasingly understand how all of these factors kind of come together to make an individual patient.
So I think the last point that you made there is so critically important. And I think it's something that urologists, urologic practitioners, even those that may not wholly manage this CRPC state, that concept and that theme of recognizing that genetic testing is a critical component in identifying targetable mutations. Maybe just for our listeners, just briefly talk about, in this realm of genetic testing, you refer to germline and somatic. Maybe just distinguish for us, what is germline, what is somatic? And then maybe I'll use that as a prompt to sort of ask you, okay, how can we use that information to then maybe offer targeted therapies?
Sure. So germline genetic testing, of course, is testing that is going to help us understand the genetic mutation landscape that a patient inherited from their parents. And this germline genetic material is shared with each of the parents 50%, but also shared with siblings and with children. An individual shares 50% of their germline genetics with their children and 50% with each sibling. And so if we identify something in this heritable gene pathway, it's really important, obviously, that we tell the patient, and it can be important in terms of therapeutics, and we'll get into that in a minute. But it's also really important that we talk to patients about communicating this with their families and support them by either providing guidance on how to find a genetic counselor or how to provide or providing that support ourselves, I guess, in some cases, in terms of supporting their family, in terms of thinking of cascade testing themselves so that they can understand if they're at higher risk of cancer syndromes as well, or the cancer syndrome as well. Somatic testing is to understand the mutation status of the cancer itself. So it is either getting a tissue biopsy, perhaps from the primary prostatectomy, or perhaps from a metastatic site, or perhaps using a liquid biopsy, getting circulating tumor DNA or cell-free DNA that we can actually get as a blood sample, or perhaps using a bone biopsy or some other method to try to get a piece of tissue from the tumor itself. And the tumor doesn't necessarily harbor all of the mutations that the patient individually has, but also can evolve its own alterations and mutations. These would not be things found in any family member, but still can be targeted with our targeted treatments, and so are important, really more so for the patient than for family members, but really critical when we're thinking about therapeutic options.
And then, just as we talk about targeted therapies, you've alluded to this several times, the concept of PARP inhibitors and other types of combination therapies that can occur with PARP inhibitors. Talk maybe a little bit about those and how you can use some of the genetic testing and the somatic tumor testing to maybe inform on that.
Sure. I think really importantly, about 50% of the BRCA2 mutations, and BRCA2 is the most common mutation that we're going to see in prostate cancer patients that can be targeted with a PARP. It's also the most responsive to PARP inhibition. We see about 50% of our BRCA2 mutations in germline testing and about 50% in somatic testing. And so to reiterate, these two different types of testing are actually important. Both are important. They're separately important. They're important together. It is really critical that we get both germline and somatic testing for every patient, so we ensure that we don't miss one of these highly targetable mutations. And so when we're getting these, we know that we can use PARP inhibitors to really target those areas of vulnerability within the DNA repair pathways, and PARP proteins can target BRCA mutations, BRCA1, BRCA2, as well as things like PALB2, other alterations involved in that homologous recombination repair pathway that allows a cell to actually repair the mistakes that are being made as the DNA is being replicated. And if we interfere with PARP, which is another system that helps to ensure that the DNA replication is viable and is correct, if we interrupt the PARP, then DNA repair defects just start building up within the genome of the cell, and the cell ends up really not being able to survive. And so we really are hitting it once with a genetic mutation that prevents that cell from repairing its DNA, hitting it a second time with an inhibitor that stops the backup PARP proteins from repairing that DNA, and the cell is really not then able to function. So PARP inhibitors can be used as a single agent in people who have these HRR or homologous recombination repair defects. Again, the majority of these are going to be BRCA2, but there are others. And olaparib is one of the PARP inhibitors that's approved as a single agent in metastatic castration-resistant prostate cancer. And it's currently approved for a slew of HRR mutations that predominantly are going to be BRCA2 in our patients with prostate cancer, but there's a list of them. And it's after patients have had progression of cancer on an AR pathway inhibitor. They could have been exposed to chemotherapy, but they don't need to have been exposed to chemotherapy. Rucaparib is a second agent that's approved for patients with metastatic castration-resistant prostate cancer, but it is approved only for BRCA1 and BRCA2 alterations, and it's only approved after progression on an AR pathway inhibitor and a taxane chemotherapy. I think importantly, you mentioned combinations. So in the last, say, 2 years, we've had some really interesting data that suggests that when we combine a PARP inhibitor with an AR pathway inhibitor, and there are 3 different combinations currently approved by the FDA, we can perhaps have a synergistic relationship between these two agents, and really an augmentation perhaps of the function and the success of the PARP inhibitor from really inhibiting that cell. So importantly, the combinations are niraparib and abiraterone, which is actually produced as a single pill. We also have olaparib and abiraterone, which is a wonderful combination also reviewed in the PROPEL trial that led to its approval. And we also have the combination of talazoparib and enzalutamide, which was reviewed in the TALAPRO-2 trial. And each of these combinations are now approved in the first-line mCRPC setting. I should say niraparib and abiraterone, which was approved after the MAGNITUDE trial, and olaparib and abiraterone are approved in BRCA1 and BRCA2 mutations only in the first-line mCRPC setting after progression on ADT essentially alone. And the talazoparib enzalutamide combination is actually approved in the first-line mCRPC setting, but for a slew of HRR mutations. So a little bit of a broader label for that one. But all of these combinations we think are highly effective, and perhaps most so in our BRCA2 mutation patients. Although, as I said, that talazoparib enzalutamide label does extend a bit more broadly to an array of HRR mutations.
So that's wonderful. I mean, absolutely a great summary that you just gave us on sort of this whole broad concept of using genetic testing and somatic tumor testing to really look at targeted therapies. So now I'm going to maybe pivot and ask you a little bit about radiopharmaceuticals. And, the first one I'm going to talk to you a little bit or ask you about is radium-223, which I feel like, if I remember correctly, I think the New England Journal of Medicine article was maybe in 2012. I mean, and so you've got all these new kids on the block, but we've had this therapy now for almost 12, 13 years that has been part of our algorithm. Maybe first talk to us about radium-223, and then, I think the obvious next sequelae is talking about lutetium, especially in this PSMA-based era. So talk to us about radium-223 first.
Sure. Yes, I do think it was 2012 when that study came out. And I remember going to the P&T committee and requesting that we have radium in our pharmaceutical opportunities for our institution. It's been a long time, and I was much younger then. So I'm glad. I'm glad though to still have this as an option. Now, radium initially approved in patients who have bone-only metastatic disease, and the label was interesting because it really described that patients should be symptomatic. And I think the way that we interpret symptomatic may have evolved over time. Patients could be before or after treatment with chemotherapy, but they were described as symptomatic. I feel like I interpreted that as symptomatic from metastatic disease. So that could be fatigue, it could be bone pain, it could be severe, it could be mild. But I didn't really use it as a reason to not give it if a patient was only mildly symptomatic, because radium absolutely is associated with a survival advantage and a disease control efficacy. So it is still an option. And I think actually perhaps even a more interesting option after an ESMO presentation that came out actually just a little bit before this podcast has been recorded. That ESMO presentation is actually on the PEACE 3 trial. We may have heard about this before when we heard about patients who were enrolled in this trial being prescribed to have to take a bone health agent because they were receiving a combination of radium and enzalutamide, or enzalutamide alone in the first-line mCRPC setting, and a previous trial, the ERA-223 trial, that used a combination of radium and abiraterone, was associated with a high level of fracture. And it was a sincere concern of the investigators that if they were using an AR pathway inhibitor with radium in this ongoing trial, that they would mandate bone health agent use in the trial to reduce the risk of fracture. The good news in that prior data release was that when that was mandated per label, we should all be doing that anyway in the mCRPC population, the fracture rate plummeted. And so the PEACE 3 trial continued, and the data just came out. The combination of radium and enzalutamide was superior to enzalutamide, both in radiographic progression-free survival and in overall survival, believe it or not. So radium is still very much an option. And now one could consider giving it in combination with enzalutamide, particularly if a patient has not had prior exposure to an AR pathway inhibitor when they get to that mCRPC setting. So really be on the lookout. That paper out there, I believe soon. I don't believe it's out yet, but I think something to be on the lookout from the Peace 3 trial. Other data that I think is important related to radium is that there is, as we think about other radiopharmaceutical agents, there's data from the RALU trial that tells us that radium is actually appears safe to use after, lutetium appears safe to use after radium exposure. So concerns about bone marrow failure and other intolerance with the receipt of lutetium after radium are actually seem to be allayed with that particular trial.
So, and then let's maybe talk about, and you've just sort of talked about lutetium, and I feel like this is now become the very new hot topic. And I think obviously the proliferation of PSMA-based PET imaging within the U.S. has really sort of then propelled this concept of, using that in a theranostic sense to effectively treat disease. Talk about lutetium. Where does it fall into the treatment pathway? And maybe what's the future of it? And I'm sure, as with almost everything, nothing is without side effects. So maybe where are we going? And then what should we be cognizant of with regards to side effects, adverse events?
Sure. So, you and I both call this agent lutetium, but I should say this is lutetium-177 PSMA-617. It's a very specific agent. And the reason that that's going to be increasingly important is because there are other agents with different PSMA targeting ligands that are coming down the line, including the one that was also presented at ESMO, the lutetium-177 PNT or .2002 agent, which was in the SPLASH trial. There's a separate one that's being tested in the ECLIPSE trial. So there are other agents that are coming down the line that are going to be using a lutetium beta emitting radioactive particle, but have a different linking ligand seeking end. So in any event, the drug that we're talking about is also called Pluvicto. But if I do call it lutetium during this conversation, know that I'm talking about PSMA-617 lutetium, because that's the one that's currently approved. This agent is, I think, really, really important to us. It is one that we can give to patients after they get to the MCRPC setting. And currently, it is approved after taxane exposure and after progression of disease on an AR pathway inhibitor. It is for patients who are selected with a PSMA PET. So patients do have to have sufficient disease that is PSMA PET positive and a lack of a higher burden of disease that is PSMA PET negative, because we wouldn't want to have a large volume or burden of disease that is not going to take up the lutetium beta emitting particle. In any event, this can treat bone lesions as well as soft tissue lesions, and is associated with both a progression-free survival and overall survival advantage in this very advanced patient population. It has been tested in earlier settings, in the pre-chemo setting, in the PSMA-4 trial, and in that setting, it was shown to prolong radiographic progression-free survival as compared to the comparator in the trial, which was the alternate AR pathway inhibitor. So the control arm not especially strong, but a fairly standard control arm in this setting, as we've seen in multiple trials that have come out. Importantly, in that trial, lutetium was available to patients who progressed on the control arm. So once they progressed on that alternate AR pathway inhibitor, they got lutetium. And so what we saw is that the overall survival curves actually nearly overlap. The hazard ratio at this point for the comparison of these treatments is less than 1 now, suggesting that it is probably maybe beneficial, but hopefully at least not harmful to get lutetium before chemotherapy or subsequent therapies, I should say. But I think it's challenging to interpret because of the remarkably high level of crossover in this trial, where basically everyone got it either early or late. In any event, the drug is approved post-chemo. We'll see if it moves to a pre-chemo setting or even earlier. And the side effects that we have to think about are things like cytopenias, and we do have to check CBCs, make sure we consider dose reductions, dose delays, or perhaps transfusions of red blood cells or sometimes platelets for patients, and really monitoring to make sure that patients don't develop more pronounced or prolonged marrow dysfunction. And a majority of patients are able to get through it just fine, but it is something to keep an eye on. Patients may also have some dry mouth, fatigue, and some GI distress, but generally, I would say a well-tolerated treatment. The only other thing to consider, of course, is radioactive safety, where patients do need to be away from adult family members or others for approximately 3 days after treatment because they are giving off this beta particle, this radiation. They need to be away from children and pregnant women or potentially pregnant women for a week. So something to be really clear with patients about and counsel them on as we're trying to make decisions too. It's something that some people consider because sometimes people can't be away from family for that extended period of time. And it may be a reason not to get treatment in some situations, though in most situations, I think people are able to come up with workarounds for that.
So you've really talked to us so nicely about targeted therapies. You've walked us through some of the radiopharmaceuticals, both what we had before and then continues, as you pointed out in the ESMO data, clearly shows what we have before isn't necessarily what we only had before, but continues to have value in current practice. What about chemotherapy? Where does chemotherapy fall into this? Where does it fall into sort of our treatment algorithm for MCRPC?
Well, chemotherapy is another treatment option that is thankfully a little bit older than I am, I hope. But in any event, it's been around for a long time. And I think it's still around because it works and is an option, and particularly for patients who are in visceral crisis, who have rapid disease progression, who are really in a state where maybe they're approaching, marrow dysfunction because of overcrowding. They really need a treatment that's going to rapidly and effectively control their cancer. And chemotherapy can be that rapid and effective control. Typically, we use docetaxel and then cabazitaxel, though sometimes because of the slight differences in side effect profile, we can consider using cabazitaxel in a frontline type of a setting rather than docetaxel. The reasons we might do that are predominantly around neuropathy, because cabazitaxel seems to have a little less of an association with causing neuropathy. And for patients who have pre-existing neuropathy, it can be easier for patients to take. They do seem to work quite well, and cabazitaxel can work after docetaxel, which is why we typically order it the way that we do. I would say that although chemotherapy has a really bad name, and this is something that is ingrained in our culture in many ways, it is better tolerated than most people think. And there are ways to support people through chemotherapy, including dose reductions, changes in schedule like delays, and perhaps giving the drug every 4 weeks if needed. There are also schedules that we can give that are really demonstrated to be effective for older adults that might be in every other week dosing, or there are lots of strategies that we might be able to use. And we can even use things like cold caps, believe it or not, to try to help people not lose their hair, which I've used for a number of individuals who, for one reason or another, want to maintain their hair, maybe to not look sick, maybe because they're still working. They want their colleagues or the people that are buying things from them or relying on them to not realize they're sick. And these cold caps can be also quite effective in helping them to maintain that. And the final thing I would say about chemotherapy is that if we do have those alterations that suggest a more aggressive disease or an androgen indifferent disease like P10, P53, or RB, if we have 2 out of 3 of those, we do recognize that we might have a better opportunity to incorporate carboplatin into our combination chemo with maybe docetaxel or cabazitaxel and get a little more bang for our buck, perhaps eke out a little bit more effect from those agents if they are starting to fail. So chemotherapy still absolutely has a place in our landscape.
And so maybe to close out our program in the last few minutes, and you've talked about this a little bit already, about the concept of immunotherapy, and I think you alluded to pembrolizumab when we were first introducing the concept of genetic testing and identifying targetable mutations. But maybe talk about both immunotherapy options, both some of the newer agents, but obviously, we'll go back in time to Cipacel-T, another one that was, sort of early on in the treatment paradigm. And talk to us a little bit about where, obviously, the more current immunotherapy agents, the PD-L1, PD-1 inhibitors, as well as some of the older agents.
Sure. So immunotherapy has been, I think, one of the heartbreak stories of prostate cancer. And it has been involved in multiple failed trials, including phase 3 trials, registration trials that have unfortunately not hit the mark. But in a small portion of patients, those patients who have MSI high status, MLH1, MSH2, and MSH6 mutations, as an example, often found in somatic testing, pembrolizumab can be highly effective and really take a PSA, sometimes even in the thousands, all the way to an undetectable level and cause disease regression. So in those in whom it works, pembrolizumab can be a fantastic option, but it is a rare patient, maybe 1% to 3% of people. Sipuleucel-T, really the first immunotherapy actually approved in solid tumors and available, as you said, for a long time for us. I do try to consider it in patients who are basically asymptomatic with a very slow disease progression, perhaps after triplet therapy or doublet therapy, where I see the PSA starting to rise, suggesting castration resistance, but maybe minimal radiographic change. This might be an opportunity to sneak in Sipuleucel-T, see if I can get some mileage. And I often will continue the AR pathway inhibitor, or sometimes switch the AR pathway inhibitor while sneaking in Sipuleucel-T, just to see if that combination perhaps can give me a little more time. And actually, not infrequently, I get a fall in PSA after an initial rise with the CYP-T, and then a maintenance while I'm on that other AR pathway inhibitor. But I think, there are other immunotherapies that are being assessed in clinical trials. These are more cellular-based type treatments, CAR Ts and BiTEs and even trikes. So there hopefully is more to come. Sometimes the toxicities outweigh the potential benefit in certain patient populations. But in general, I think these are going to be very exciting advances, especially in patients who are a bit more fit and who can tolerate a little bit of cytokine release syndrome, and clinical trials to continue to evaluate them and hopefully help adapt them to be able to give in a broader patient population may make these options a reality for our more frail patients at some point in time as well.
Well, that was really super. I love doing these with you, Alicia, because every time I learn a little bit more. So I feel like I've got to keep you on the clock every 6 months so I can keep my own sort of knowledge base going. But you're always so articulate. I think you do a fabulous job, and really a huge thank you for spending some time with us this afternoon on this podcast.
Thank you so much for the opportunity. It is always my pleasure to talk to you.
Thank you to our audience for your time and for your attention. For more information, please visit us at auanet.org/university. Alicia, I hope you have a wonderful weekend, and best to you and your family.
Thank you. And to you too.